The Ministry of Health, we have a program with the National Ministry of Education, the School Health Program, where we target inculcating healthy behavior among the school-going children. Amongst them, one of the programs that we run is the School Deworming Program. We know the importance of children as agents of change in the community in terms of health behaviors and health generally, even influencing the parents in healthy behaviors. So we use children, and the program specifically on school deworming targets to deworm school-going children between the ages of 3 and 14 years in the Republic, who are about 12 million in the country. As the National Ministry of Health, through research, we have identified 27 counties with the highest burden of worms or helminths or soil-related helminths in the country, and also schistosomiasis, which is bilharzia. And these are the counties with bilharzia problem are 14 counties, but there's other deworming for soil-borne ailments are 27 counties. These are the counties that every year we run a program of deworming children. We have this year run a program of deworming children, first targeting 13 counties, where we reached 2.8 million children, and that was in February this year. And again in September, we also ran another program of deworming children in 14 counties that is targeted to reach about 4 million children. This was done between the 14th and 16th of September this year, and is still ongoing on some parts of the country. But the national launches were done on those dates that I've already mentioned. School deworming is very important to, one, ensure children are healthy, are free from ailments, which affect, one, their cognitive development in terms of ability to concentrate in class, ability to understand. Also affects school attendance in terms of children who have worms occasionally miss research, and also affect the nutrition of the children. Of course, the most common types of worms in our society are ascaris rubricoids, ascaris, which are called pinworms. Then we also have other tapeworms, other soil tapeworms, and pinworms, or what we call roundworms, are the most common. But we also have other uncommon types of worms across the country, depending on areas. These are, of course, spread through the fecal, which is a sanitation issue as well. Okay, this is yes, this is also spread through interaction with contaminated soil, especially from human and animal feces. So some of the of these worms have hosts in animals and are spread to humans, and therefore interacting with feces or contaminated soil from animal and human waste can result to that. These worms are common in areas where, first, sanitation, hygiene is not good, and this, of course, obviously goes to the areas that are urban. In urban areas, is mostly the low-income settlements, low-income settlements. In the areas where there is a lot of water, poor drainage areas, I'm talking about the slums. In rural counties, you will find areas where sanitation coverage or open defecation is common, being part of this. Some of the counties that I'm talking about are counties in the coastal region, all of them. Counties in the eastern region, all of them. I'm talking about Mombasa, Lamu, Tana River, Kilifi, Taita Taveta, Kwale, Makueni, Machakos, Kitui, to some extent Embu, we have Kisumu, Homa Bay, Siaya, Nandi. So it's a constellation of counties, and of course Nairobi being one of the areas with the highest informal settlements in the country.
So what is the danger in living worms untreated?
Living worms untreated in children, first they share nutrients with the children. So the children may be getting enough food intake, but the food is not available for the child for growth. So it affects children's growth, leading to malnutrition, leading to stunting. Malnutrition in children also leads to poor brain development, and therefore concentration in class, and frequent absenteeism from school because they have stomach problems. These are now the acute symptoms of worm infestation. Children will have frequent abdominal pains. They may develop complications, which sometimes include intestinal obstruction, resulting to surgical emergencies, children needing operation as a result of worms. Children will develop other symptoms of worm infestation, like anemia, that of course affects their well-being in terms of they are unable to actively participate in sports or other children activities. Children between the age of 3 and 14 years should deworm at least twice a year, every 6 months. In areas where resources are available, this can actually be done every 3 months. But in a resource-limited environment like us, our policy is we do once every 6 months. So every child in the age of 3 to 12 to 14 months should at least get dewormed once every 6 months. One, because of resource constraints, and we are working with Evidence Action as a partner who has been supporting this program for the last 9 years. We are unable to marshal the resources that are required to do at least twice a year deworming. What we are doing is doing once a year deworming, which is of course better than not deworming. But the target is to encourage counties to also commit their resources so that the national ministry leads the national program of once a year, and the second deworming can be done by the country because the countries also have resources, and health in this country is devolved, and the counties have a big role to play in delivery of health services. So there are some counties that are already doing that, that are able to mobilize their resources and deworm their children for the second dose. So, but we say in resource where we have limited resource environments, once a year is good enough, because as you routinely continue to deworm these children, remember you kill the worms, and therefore the environment does not continue to have worms being discharged into, and therefore what that means is there is not much exposure even in the natural environment. When we say it's a Ministry of Health and Ministry of Education, we are not talking about private or public. We are targeting all schools in the Republic of Kenya, in the 27 counties, whether private or public, yes. The country can be categorized into three, and this is a research and that was done in 2011, 2010, thereabout. Country categorized into three. Counties that have prevalence of between 0 and 20%, which are now the 20 counties that are not target of the national program. Then we have counties that are between 20 and 50%, and counties that have above 50%. As at the last research, in the year 2000, there are counties that were above 50%. But the research that was done in 2010 pointed all the 27 counties were between 20 and 50%. So currently in Kenya, and that is a review of that research is to be undertaken this year, later in the year, we will be able to know where we are in terms of the change. Some of the counties that were between 0 and 10 could have gone to 20 and 50, and those that were between 20 and 50 could have gone down. So that was the basis of our programming. We have, like I mentioned, we have the school health program that has several components. There is school sanitation in school. There is the nutrition, health education in school. There is there is there is sanitation. There is health education. There is menstrual hygiene. There is of course gender mainstreaming or gender issues, adolescent and teenage pregnancy, reproductive health, all those HIV, all those programs are undertaken in the school health. Meaning, nutrition as well. We have also immunization, vaccination, especially for school girls, for children, for girls between the ages of 10 and 14 against HPV virus. So all this, we look at the child holistically in school, so that we also have school hygiene programs that we run, ensuring that schools have hand washing stations, school have clean water for drinking, school have source of treated water for children, and these are programs that we run with the Ministry of Health. COVID-19 emergence in 2020 has also strengthened that component of holistic approach of school sanitation health. School sanitation also includes ventilated and improved latrines, ensuring that there are waste, safe disposal of human waste in schools. The same with the communities through the community health strategy and through the public health department. We have what we call the certification of villages and communities of open defecation free, which is now community sanitation, which you work together with the community health volunteers and community health extension workers to ensure that the environment of the child at home is also safe, so that we do not have one area that is preventing these diseases and another area which is propagating them. So that's the holistic approach that we have. And we know, and why we continue to use students, and as I had mentioned it, children are actually agents of change. If, like for example, children learn that your household does not have a clean latrine, for example, or a toilet, then they may go and tell the others, and the parents may be compelled to have them as a result. I was talking as children as agents of change, that they are able to influence what their households and their neighboring households do, or their friends' households do, in terms of ensuring certain standards are maintained within the community. So far, we have not any major challenges. Maybe the usual logistical challenges in terms of limitation of resources getting to every school, the supervision, but generally there has been very good reception because we have been collaborating very well with the Ministry of Education, and of course the Ministry of Education is able to mobilize the parents. I do not have the data of that, but I would not be surprised because um, we have a diverse community, culture, social cultural. In terms of, there are those communities that do not believe in conventional medicines. There are those religious beliefs that do not believe in use of drugs, and therefore I expect that we get that in every program that we want to deliver health services, including vaccinations, including, so that I think to me is a normal occurrence in terms of some social cultural alignments. Yeah. We assume because children cannot give consent for their treatment, so we assume, and parents have given consent. So unless the caregiver gives consent for their child to be given treatment or this deworming, we cannot, as a ministry, force, because we use a human rights based approach to delivery of services. I think we have cumulatively been able to deliver over 60 million doses of dewormers in the Republic over the 10 years this program has been running, which is commendable. That means one, in terms of, because research has shown, deworming children at least once a year. For every shilling invested in deworming gives returns of up to 25,000 shillings. So in terms of the economic benefit that has been realized as a result, because this cohort of children will grow up have higher potential than they would if they had not been dewormed. In terms of also cleaning the environment and for the future, removing the elements from the environment is also eradicating the elements is also a major step that has happened. So these economic benefits will be realized in maybe in the next 5-10 years when school performance has been able to improve by, as research has shown, by 7.5% as a result of deworming exercise. So the taxation benefit from research will be yielded when these children who have been dewormed grow up to be adults and be productive members of the community. Why we don't run a program of adults is because one, the effect of helmets to adults is not as much as it would be because of sheer volume, sheer size would not be as much as in children, but it is necessary that adults also deworm as a health as a healthy move to ensure that you are free from harm. Because even as we talk about children who are more affected, the the development of children, they are more likely actually to get worms because one, they play with the soil, they play in the environment, like adults, but adults are also advised to deworm at least twice a year. First, undertaking a review of the program and see whether the prevalence of soil transmitted elements in the country, worms in the country, is as been done. So that will guide us in terms of reaching, reprogramming, and determining who to target. We also working with the leadership of the ministry and National Treasury and Ministry of Education to make a case for more resources towards this so that more money is available to reach the 6 million other children that we do not routinely reach to as a result of lack of resources, and as well be able to do this exercise twice a year. So that is our focus, that we reach all children in all parts of the country and not just the counties that have higher prevalence of these soil-borne ailments.